Let's turn it over to Dr. Drain. I'm going to briefly present Paul. So Paul is infectious disease doctor, has appointments in the ID division and the global health division at the University of Washington. His research focuses on the diagnosis and screening for TB and HIV in resource limited settings. He has a number of important leadership roles in that regard. He is the director of the UW Clinical and Translational Research Program within the International Center for Clinical Research, and is the director for clinical and translational science core, excuse me, for CTRAC. And it looks like we also go to the same shirt salesperson. So without further ado, please take it away, Paul. Paul has agreed to make this interactive and allow people to interrupt with questions. So if you have questions, raise your Zoom hand and or just speak up or put it in the chat. All right, take it away, Paul. Thank you.
Great, great. Thank you so much, Bizan. You can see my slides okay? Looks all right?
Yeah.
Okay, great. Well, thank you. Thank you so much for the invitation to be here with you today. I was looking through the participant list and I see some familiar names, which is great. So yeah, thanks Bruce Chandler in Alaska and others for joining. It's great to see you all on the call. So I'm going to talk a bit about the global health impact of TB and the role of point of care diagnostic testing. This might be a little bit different from what most of the TB echo community is used to of dealing with particular patient cases and thinking about the guidelines that we have here with the CDC and the FDA in the US. This is perhaps going to be a little bit global thinking and maybe forward thinking in terms of where we are with TB globally and thinking about the WHO, the World Health Organization, and recommendations. And I'm going to spend a bit of time talking about some of the exciting new diagnostic tools that are also coming for tuberculosis. And at the end, I'll describe a little bit about some of the work that we've been initiating in Alaska, which I'm particularly excited about. And please feel free to interrupt me at any time, ask questions, raise your hand. I don't know if I can see hands being raised, but maybe Bijan will let me know if there's questions. Just a few speaker disclosures. I do have financial relationship with several companies that are involved with TB diagnostics. I just want to say that the content and views expressed in this presentation are mine and don't represent the funding agencies or sponsors. So what I want to go through with you today is we'll talk about some of the existing gaps in screening and diagnostic tests for TB that can really help to better inform clinical decision making. We're going to describe how these point of care tests can be used for screening and diagnosis, particularly in resource limited settings, and how they might be used to increase a timely clinical response for patient care. So I'd like to start off with just an overview and put tuberculosis in the global context. So TB is still among the top 10 leading causes of death worldwide. Even though the infection has been around with us for several millennia, it still amazes me that people don't recognize that TB is still a major cause of death worldwide. TB is the leading infectious cause of mortality globally as well. So COVID had surpassed TB for a couple of years, and I haven't looked at the data for this last year, but I would imagine that tuberculosis is now back on top as the leading infectious cause of mortality as we've rolled out the COVID vaccines. And tuberculosis also remains the leading killer of people with HIV worldwide. So each year we get around 10 million people that become sick with tuberculosis disease. Most of these cases occur in just 6 countries that are shown at the bottom. Almost 2 million people die from tuberculosis each year. This includes about 500,000 people that are living with HIV. And we still get around 400,000 cases of drug-resistant TB and around 50,000 cases of XDR TB. That's the extremely drug-resistant TB each year. So the global context and the scale of tuberculosis is quite enormous. There are some positive changes, though, that we want to take away from where we are with the TB epidemics. This is the gradual decrease in TB mortality since 2004, when tuberculosis likely peaked. This graph on the left shows the percent change in TB mortality between 2015 and 2020. And the more blue the area is, the greater the decrease in TB mortality. So that's a good thing. And you can see the deaths, the graphic on the right, the deaths from TB have been decreasing both among all ages, shown at the top, but also among those 15 to 49 years of age, shown at the bottom. So we are making progress in reducing TB mortality, which is great. However, we still have about 3.5 million people worldwide who are missed out, are considered missing TB cases. So these are either people that are not diagnosed or not recorded, or don't receive treatment. This appears to be roughly the same number each year. So despite many of our efforts in developing new interventions, new implementation processes, and new diagnostic tools, we're still missing about 3 to 3.5 million people per year who have active TB disease. And you can see the 12 countries that carry most of this burden for the missed cases. So perhaps it's not too surprising, just looking at the Western Hemisphere, why most people, including a lot of clinicians, don't recognize that TB is a major cause of morbidity and mortality around the world. And I think part of the solution is we need novel TB diagnostics to get better access to care and treatment. So we have a very robust TB vaccine pipeline. This is shown on the left-hand side of the screen. There's a lot of vaccine candidates that are in early phases of clinical trials, phase 1 and phase 2. And we have several vaccine candidates that are also undergoing phase 3 trials as well. This is quite an exciting area, and we think that we'll get some new, better vaccine candidates that could replace BCG within the next 5 to 10 years. We also now have a very robust TB drug pipeline that's shown on the right-hand side. Many of these are in early phases of development, but there's several candidates, as you can see, in phase 1 and phase 2, and even one candidate in phase 3 trials. So we have a very robust drug pipeline, which we haven't seen for many decades, but we're missing a very robust pipeline for diagnostics. And I'm going to go through kind of some of our current thinking and where we are with diagnostics and where we expect the trends to go over the next several years. But first of all, we need to really rethink our approach to TB diagnostics. So you can see on the left-hand side, there's a conventional model that we currently use for many of our TB diagnostics. So microscopy, looking for AFB bacilli. We use centralized lab-based nucleic acid amplification techniques. It's still single disease testing. We're relying on sputum. Oftentimes our analyses focus on test accuracy. And these are mostly tests that are manufactured in high-income countries. The new paradigm, which was really put forward by Madhu Pai in this great article that was published last year, it's really thinking about moving away from microscopy and going to molecular testing, thinking about decentralized point of care nucleic acid testing, perhaps using multi-disease testing if we want to also include COVID or other respiratory infections, looking at testing non-sputum samples. So this is a picture of a tongue swab. I can talk a little bit more about doing testing as closer to the communities and focusing on a diagnostic yield rather than on accuracy. So if we can pick up more people, even if it's a less sensitive or less specific test, it might have more of a population impact than a test that is near perfect, but very difficult to implement. And I just put here, this is the WHO consolidated guidelines on rapid diagnostics for TB detection, if anybody wants to go a little bit more into detail. And of course, there's a lot of references and papers that are listed in there as well. We've also been rethinking our spectrum of TB pathogenesis over the last decade as well. So this is really just looking at the various tests and symptoms on the vertical axis here, and really a progression of disease from all the way from the infection being eliminated with or without an innate or acquired immune response to latent TB infection here in the middle that we would think about doing a TST and preventive therapy. And of course, on the right is active TB disease. But now we've got this category in the middle that's really been confusing a lot of people, which is subclinical TB. So now we have people who we can find the TB bacilli in a sputum or other biological sample, and we don't really know what to do with this group of people. We know that people are now on a spectrum from infection to disease. It's no longer a dichotomous infection versus disease, but we know that people kind of pass through the subclinical TB disease. We still don't know if they're infectious to other people, if they're capable of transmitting, and what the appropriate therapy would be for these people. We also have a pathophysiologic perspective as well. So let me orient you down to the bottom left. This is where somebody might become infected with tuberculosis. The red lines are the potential infection or disease courses that somebody may take. So they could progress very quickly into a primary TB infection in this early phase. And the vertical axis is the disease burden going up. However, that's pretty rare. It doesn't occur too often, maybe less than 5%. Most people go on to this latent TB phase where they can remain latent throughout the course of their infection, or eventually they can develop sort of an inflection or a turning point here and then start progressing and having a higher disease burden, more bacillary load, and eventually progressing up here to active TB disease. So now we can look at several different categories. We can also look at TB being eliminated from the body. We can look at, here's our subclinical, so before they develop clinical symptoms, and then active disease being at the top. So these green circles represent where we have existing tests. So we're very good at diagnosing people with active disease once they become sick with our sputum-based tests. And we're also very good at doing TSTs or IGRA testing to catch people on this latent TB spectrum. We generally don't know with our IGRA test whether somebody's at the beginning and they still have the possibility of progressing on to active disease, or if they're closer to the end on the right-hand side, and maybe their chance of progressing to active disease is less likely. Nonetheless, we have all these blue circles, which really represent all of our diagnostic gaps in TB. So we don't have very good tests to identify people with primary TB that have progressed very quickly. We certainly don't have tests of TB cure, looking at those that have eliminated infection. This smaller circle in the middle is looking at incipient TB. Can we find tests such as transcriptional signatures that really identify when somebody has started to progress towards active disease? And then we have this big area in the middle, which is really sort of a subclinical TB space. So how do we identify people and get them diagnosed really before they have this onset of clinical symptoms? We think that once they get the onset of clinical symptoms, then they're likely to be infectious and transmitting disease to other people. So clearly we want to get people before they become sick. And the other way I want to present of thinking about TB disease is with this treatment, response, and cure. So this relates a little bit to the question that Craig was asking. And we have this period before transmissibility of subclinical TB disease, we think. We're not sure if these people are really transmitting TB or not. But this is our severity of TB infection that keeps going up and up. And now we have this big infectious window with the highest risk of transmission. Of course, once they get in here, we want to start them on TB therapy. And these blue circles are really representing we don't have very good biomarkers for treatment response and also for treatment completion or treatment cure. So this is another major gap that we have that we've been working on with some of our studies. Okay, I've given you the perspective of diagnostics and our gaps. I wanted to go through a little bit of where we are with our TB diagnostics and where we see some promising studies and changes coming over the next several years. Just as you can probably tell, I enjoy a bit of medical history. This is just kind of going through how tuberculosis has really influenced medicine and diagnostics over the last 2 centuries. Many of these devices, including a stethoscope, chest X-ray, were really developed for the purposes of identifying TB. As of about 15 years ago, however, we only had about a half of the clinics in sub-Saharan Africa having access to mycobacterial culture. So even though these devices have been around for a long time, the access has been a major problem that we've seen. I've listed out down here in the bottom left some of the WHO endorsements for new products that have been developed for TB. You can see between 1980 and 2008, there's big gaps in our development for TB diagnostics. And then we started getting line probe assays. I think many of you now are probably pretty familiar with this Expert MTB-RIF assay. It's pictured here in the middle. Oops, excuse me. Pictured here in the middle, which is a rapid nucleic acid amplification test. It takes about 90 minutes, and you can put in a raw sputum sample. I'll talk a bit about this Determin-LAM assay. So this is a urine-based assay that has been approved by the World Health Organization for people living with HIV and have immunosuppression. The LAMP is another rapid test for TB that's using isothermal amplification. And then just recently, the WHO has also approved molecular drug susceptibility testing on several different platforms as well. Okay, so I want to show you some of the categories for TB diagnostics. So this is how we think about evaluating them in many of our different settings where we do research, either in Southeast Asia or Sub-Saharan Africa. We generally start with screening tests, and a lot of the innovation here has been around cough detection, digital chest X-rays with AI interpretation. And I can show you a little bit more data about that as well. We have this second group, which is really meant to be really community-based or point-of-care molecular tests. These are small, portable, rapid, very specific and low-cost, easy to use. The idea is that these tests would be able to be used either in an emergency room, a clinic, an urgent care center, and in many cases where we have TB endemic communities, to actually be used in community locations by going out into community centers. We have near care molecular tests. This is really the GeneXpert type test where it has to be located on a bench top. It's really not movable, but these can be rapid and accurate, low cost. The expert now categorizes MDR-TB, and there's a separate cartridge that can look at XDR-TB. And now we have this group 4, which is reference molecular tests. So South Africa has recently introduced several new, very large, but very fast and efficient reference molecular tests that are providing additional support for the GeneXpert test. So these are located in clinical labs, and they do very high throughput testing and can also capture MDR and XDR. We have this group 5, which is looking at urine LAM assays and biomarkers. So traditionally, this has been a very difficult column in group because people have concerns about what to do with these tests and how they should be used, whether they should be used as screening tests or diagnostic tests, or if somebody's positive, do you still need a confirmatory test? So we can go through some of that. And then, of course, there's tests for latent or incipient TB infection. So these are people that have become infected and may be progressing on to active disease. Okay, so I want to talk a bit about this lipoarabinomannan. This is the urine test I showed you on the prior slide. This has been approved by the World Health Organization since 2015, has not really been endorsed for use in the United States and is not widely used. But there's a lot of advances that are happening in this, and I think you'll all need to become familiar with this at some point in the not too distant future. So what is LAM? So this is it's a glycolipid that is comprised of about 60% of the mycobacterial cell wall. It's released from degrading or metabolically active bacteria. It's also secreted from macrophages. It can be recovered in cultures of MTB and measured with an ELISA. And it's been detectable in breath, blood, and urine of people with active disease. And there's three major classes of LAM, which I don't need to go into, but it's just different structures of various mycobacteria that you can see down here. Okay, so this was a rapid lateral flow assay that was developed in 2012. It's a urine-based test. It only takes 60 microliters of urine, which is about 2 or 3 drops of urine. It can be completed in 25 minutes and has a low cost. So this is based on a lot of research, laboratory-based research that was done over the last 3 decades to get down into a lateral flow strip that is really easy to use at the clinics and can be used in community health centers as well. Some of the items that are required for doing this lateral flow urine LAM testing, it comes in these strips. There's really no cassette, so you just have to peel back the foil from the test. And there's a reference scale here as well. So the positives can be graded on a scale from 1 to 4, and there's a negative, there's package insert instructions. And really, one just needs a urine collection cup, a very small pipette, and then a timer to run this as well. This is what the reference card looks like. So I think at this point through COVID, we're all very familiar with LFAs. I've been pretty amazed at how with the COVID epidemic, suddenly everybody knew what a point of care test was. I didn't have to explain anything. And they said, oh yeah, an LFA, we can run that. We can even do that in our homes and in our clinics and other locations. So maybe one of the few positive sides from COVID is now that there's a lot of interest in discovery in lateral flow assays. This is just reviewing some of the data behind this urine LFA. So a number of studies have been done so far. And really what all of these studies have shown is that the assay works quite well for people that are HIV positive, either adults or children, and have a very low CD4 count. So currently it's approved for people with a CD4 less than 200. And unfortunately, that's a very small minority of our population that we see here in the United States. And we've also found that LAM is a very good predictor of mortality as well. So, we don't want to be chasing a biomarker if it's not going to give us any valuable information. And these are studies, a meta-analysis that, looked at LAM across different settings, across different people, and it remains a very significant predictor of mortality. There's also been 2 randomized trials that have looked at this lateral flow urine LAM assay, and they've shown benefits for outcomes. So both of these were hospital-based studies done in South Africa primarily, South Africa and Malawi. And both of them found that by diagnosing people earlier and faster using this urine-based assay, and getting people under treatment faster, it actually improved mortality or reduced mortality. So these were 2 positive RCTs that really led to the WHO endorsing the urine LAM test as well. We've also seen several studies for the LAM use in children. So it doesn't work quite as well. There's only moderate accuracy in children. But of course, the challenge in children is always getting a good gold standard diagnostic. So, trying to collect a sputum in young children is extremely challenging, and oftentimes it's really relying on multiple different sample types, which are very hard to get. Okay, so where did this leave us? This left us with the WHO endorsing the lateral flow LAM assay in 2015. They had several initial criteria that it should not be used to diagnose TB, except for those people living with HIV and having very low CD4 counts or seriously ill. It can be used in the inpatient setting of people with signs and symptoms. Initially, it was recommended for CD4 count less than 100, and that's now changed. They've also emphasized that it should not be used as a screening test for TB. The other thing they emphasized in here, which I didn't put in the slides, is they said, well, if somebody is LAM positive, they should still undergo a sputum-based diagnostic for confirmation. So since that initial policy in 2015, there's been a lot of changes in expansion of this particular urine-based assay, as well as expansions in rapid diagnostic testing as well. So now currently it's been expanded to include inpatients with a CD4 less than 200 and outpatient settings for people with a CD4 less than 100. Of course, we know that that's still a very small minority of the global population that has tuberculosis. So worldwide, generally only 10% of people are living with HIV among all of the 10 million that develop active TB disease. So really, this test is just catering to less than 10% of the people that we want to be testing in screening for tuberculosis. By 2024, this year, the WHO had changed their guidelines slightly more to include HIV positive adults, adolescents, and children. So this includes all HIV positive people who may be symptomatic for TB, irrespective of CD4 count. It can be used on inpatients who have a CD4 less than 200, and then for outpatients as well. So really trying to recognize that we have our first true point of care test for TB that doesn't require the support of a laboratory or molecular testing, and really trying to expand the definition as much as possible. But we still recognize that we're not meeting all of the needs that we have for a urine-based test for TB. So it still has very poor sensitivity among HIV negative people. It uses a very small volume of urine. As Kayvon pointed out, there's a limited antibody affinity. So the antibodies that are being used in the lateral flow assay are the same ones that were identified and developed more than 20 years ago. And we need to apply some methods to concentrate the urine specimen for testing. So now there's a lot of work that's going into a second generation urine LAM assay to make it more sensitive for HIV negative people who may have TB disease. So this is why I think all of you should be familiar with this background on urine LAM. These are just some of the companies that are working on developing a second generation urine LAM assay. I do work with some of these different groups and have seen some of the emerging data, and I can say that it looks quite promising. It's really using some new antibodies, new monoclonal antibodies that have much better affinity and more specific affinity for the MTB LAM. And there's also various methods that are being employed to try and concentrate the urine sample. Of course, if we're just testing 60 microliters, that's a very small fraction of the urine specimen that's being provided. So many of these tests are actually testing anywhere between 5 and 10 mLs of urine, which is a much larger volume. Okay, I want to pivot a little bit to tell you just about some of the research that's going on in these other groups as well. So in this first group, there's a lot of attention recently on digital chest X-rays with computer-assisted detected or AI interpretation. So this is really taking a conventional chest X-ray, capturing it as a digital image, and then applying these computer algorithms to really interpret the chest X-ray in real time without the need for a radiologist. And oftentimes these reads can come back in 10 to 20 seconds if there's good connectivity. So I'll show you what that looks like. There's been a lot of work going into various cough sounds, either the frequency or what the sound might register as. There's some digital stethoscopes that are being used to try and identify TB breath sounds. There's various wearable devices that are being evaluated. And there's still some work going into C-reactive protein, which most of you know is a very general inflammatory marker, but does seem to be elevated in almost all people who have active TB disease. So again, a screening test, not a diagnostic test. There's a lot of work going into these rapid molecular tests, whether they're point of care or near care molecular tests. That's the group 2 and 3. These are non-sputum specimens are really being preferenced. So there's work going into evaluating them on tongue swabs or blood samples or urine samples as well. And then there's some renewed interest in work going into reference molecular tests. And I think we'll get to a point relatively soon where these reference molecular tests will completely replace mycobacterial culture. These are starting to do more expanded drug susceptibility testing and targeted next-gen sequencing, and they're not too far from being rolled out in many of our settings. So let me just show you a couple of these with a little bit more information. This is what a digital chest X-ray with AI interpretation might look like. Here's a chest X-ray machine on a tripod. So somebody can hold the X-ray plate in front of them, or it can be put on a wall. These are small and portable enough that they can be carried out into community settings. They don't require a large van with high amounts of power. And as long as there's connectivity and a laptop or a reader, then they can be applied to the software that's doing the interpretation for them. And the WHO has already endorsed these digital X-ray devices with CAD interpretation, and that was done a couple of years ago. So now these are being widely rolled out in many TB endemic countries, and we're starting to evaluate this in some parts of Alaska as well. In terms of testing by molecular devices, I just wanted to show you a few of the devices here, some of which we're evaluating in South Africa that appear to be quite promising. So there's rapid molecular tests. Of course, you know about, these are ones that are approved. You know about the Cepheid. There's another one by MolBio called the TrueNat, which is an isothermal amplification. And there's TB-LAMP by a Japanese company called Icon. There's several lab-based molecular tests. So these are on the relatively large clinical lab machines. And the WHO has already endorsed different line probe assays and next-gen sequencing for resistance testing as well. And these are the four pictures of devices that we've been developing. These are not yet approved, but I am expecting many of them to be approved in the next year or two. And these are really true portable Category 2 devices that can be carried into the community and done quite rapidly. Okay, so with that, I wanted to share a little bit about some of the work that we've been doing with Dr. Bruce Chandler and his team in Alaska. It looks like my animation thing's not coming up very well. But tuberculosis has a very long and deep history in Alaska, as many of you know. And by the middle of the last century, tuberculosis was the leading cause of mortality in Alaska, and really contributes significantly today to a high mortality rate, particularly in the southwest and northwest portions of Alaska. Um, so we've been working with the YKHC team and the State Department of Health. These are just some of the data that we're starting to evaluate. And here you can see the TB incidence rate for tuberculosis. So the YK Delta is the southwestern portion of Alaska. Let me pull up the map here. So the southwestern portion of Alaska, which is a very large geographic region, with relatively small villages that are quite isolated. And the village A, B, and C are three different villages in the Alaska region. And you can see that the YK Delta, which is the third line, the solid orange line, has TB rates that are really on par with Uganda and Vietnam, many other countries that we would consider to be TB endemic. So now we have a situation in the southwest and northwest part of Alaska where it's really TB endemic regions. So, most of us in Seattle really think about TB as being an imported issue among travelers, bringing TB in from whatever TB endemic country they may have visited. And now we really need to start thinking about TB in Alaska in a very different context, in the sense that this is already there in their communities. This is not being brought in by people that have visited other regions, but being spread throughout the communities. So this is an exciting project that we're just getting started on. We are looking at some of the digital chest X-ray devices and see how they can work, and then once we look at some of the rapid molecular tests in South Africa and categorize them a little bit better, I think we'll be able to bring them to Southwest Alaska and see how they can work on reducing TB in the population there. So anyway, just in summary and conclusions, I think I've gone on a little too long. We need to use better screening tools for TB. I think the digital chest X-rays with AI interpretation, not having to wait for a radiologist to read a printed chest X-ray, certainly makes a lot of sense for TB endemic regions. I think we're going to be deploying the use of the urine LAM assay. It's an approved point of care test. There's still a lot of work and a lot of promise going into a new test, and I think we'll get to a better urine LAM test relatively soon. There's a lot of rapid molecular tests that would be a good path forward. Certainly in the United States, this could be used either in emergency rooms or clinics, some hospital settings to try and identify tuberculosis quickly, really to protect the health workers and the staff. I think the symptom screening, microscopy, and culture may start to become extinct. Certainly the microscopy, we're seeing that there's little value and it's very time and resource intensive. So as we get these newer tests, I'm expecting microscopy and eventually culture to really just become a reference test for surveillance purposes. Obviously, we still need coordinated efforts to inform public health leaders and clinicians as well as their patients. Finally, I just want to end with some advocacy and action for TB elimination. We're still very far behind in meeting our goals for funding research and care for tuberculosis. So when we look worldwide, only 1 in 4 people have access to MDR treatment. The funding gaps are still fall well short of what we need to eliminate TB. So it's estimated that we need about $10 billion required for TB implementation, and we have a funding gap of $3.5 billion. And for research, we really need a $2 billion budget for TB research, and our funding gap is $1.3 billion. So we're not even getting half of what we really need for TB research. I think many of you know there was a lot of excitement last September when the United Nations held a very high-level meeting to end TB. So this is very much in the global conversation. And really their theme was to advance science to urgently end the global TB epidemic, which was quite exciting. Finally, I just want to put in a shameless plug for a course that we teach here at the University of Washington that Bijan and many others have given a lecture in. We just held this in September. It's a 1-week virtual course. We cover each day, we cover various topics that you can see in these different bullet points. It's really a great learning opportunity. It's all virtual on Zoom, and we update it every year with new speakers and new presentations. So thank you very much for having me. I just wanted to acknowledge some of my funding support, and I'm happy to take any questions you might have. Thank you very much.